Thank you, Dr. Kluge. So our topic today is HIV and contraception. It's not a very long presentation, but we did aim to highlight only the most important points. So we'll briefly have an introduction. We'll look at the medical eligibility criteria, the Kenya study that was done, as well as the WHO recommendations, which we will end off with. So Kevin was quite right when he said when you do a Google search on contraception, you will get about 20 million results related to contraception. And some of the related searches that you will get is the type of contraception, natural contraception. They even have contraception wiki, contraception options, and the definition of contraception. So just some interesting and shocking factors about HIV. They say globally around 40 million people are infected with HIV. A young Swazi girl has a greater than 80% chance of dying from AIDS in her lifetime. Over 900 million children become infected with HIV each day globally. Sorry, 900 children, not 900 million children. And in Botswana, the life expectancy actually decreased from 65 to 35 years of age. AIDS is the most studied disease in history. And the first major Hollywood film to focus on AIDS was in 1993. It was a film called Philadelphia, and Tom Hanks actually won an Oscar for his performance. And globally, nearly 18 million children have lost one or both parents to AIDS. A bit closer to home, the prevalence of HIV in South Africa is around 6.1 million. That is roughly around 1 out of every 10 people. 4 out of 5 people with HIV between 20 and 24 years are women. The prevalence among pregnant women is the highest in KwaZulu-Natal, and that's around 37%. And in 2011, more than 2 million children were orphaned due to HIV/AIDS in South Africa. So if we have a look at the definition of contraception, they say it's the deliberate use of artificial methods or other techniques to prevent pregnancy as a consequence of sexual intercourse. So it's obviously important that people are aware of contraception and the different options available. However, if you are completely dogmatic about the definition of contraception, then there are certain people that don't require contraception at all. And this can be due to religious reasons. It can be due to sexual preferences, or it can be due to moral beliefs. So to understand the use of contraception, we need to be aware of the medical eligibility criteria for contraceptive use, or the MEC criteria. And the MEC has applied a 4-category scale to indicate eligibility for particular contraceptive methods in the presence of particular conditions or characteristics of a patient. So your category 1 indicates medical conditions or personal characteristics for which there are no restrictions on the use of the particular contraceptive method in question. Conditions classified as category 2 indicate that the contraceptive method can generally be used, but careful follow-up may be necessary. Category 3 conditions are those that require careful clinical judgment and access to clinical services. In these situations, the severity of the condition, availability, practicality, and acceptability of alternative methods should be taken into account. So the use of a method for a category 3 condition is usually not recommended unless more appropriate methods are not available or acceptable. And then obviously your category 4 conditions are those where the method should not be used because the condition represents an unacceptable health risk. So just to make it a little bit more interesting, if you have a look at this picture, I know it's a bit out of focus, and you say that this baby is Vaughan Marshall, then it's obviously wrong. So that will then be a category 4. If you say it's Norma Mbungu, you're still wrong, but not as wrong as by saying it's Vaughan Marshall. If you say it's Kirisha Naidu, she's one of our students, or it's Sumaya Shah, you are right, on the right track, but you still need to differentiate between the two. So for this picture then, to qualify it as a category 1, you need to say that this is Sumaya Shah. This was taken a few years ago, and yeah, you can actually see that it's Sumaya. So just a quick reminder about fixed dose combination. In 2012, Minister of Health, Dr. Matsoaledi, announced the award of a new antiretroviral tender that for the first time since the start of the ARV program, it includes a triple fixed dose combination. So from April 2013, all pregnant women, regardless of their CD4 cell count, were initiated on triple ARV therapy. But concerns have been raised about efavirenz reducing the effectiveness of contraceptive implants. So in Kenya, they did a retrospective cohort study where they aimed to establish whether pregnancy rates differ between HIV-positive women who use various contraceptive methods and either efavirenz-based or nevirapine-based ARVs. So the study was done in HIV-positive women aged between 15 and 45 years, and that was done between January 2011 till December 2013. And their primary outcome was the incidence of a clinically diagnosed pregnancy. So at each clinic visit, the contraceptive methods were documented then as either implants, your Depo-Provera, combined oral contraceptives, your more effective contraceptive methods, which includes your IUCD or permanent methods, less effective like your condoms, or no contraceptive method at all. And their main findings were that for HIV-positive women using implants and efavirenz-based ARVs, they had a 3 times higher risk of contraceptive failure than did those using nevirapine-based ARVs. But these women still had a lower contraceptive failure rate than did those receiving all other methods or all other contraceptive methods, except for IUCDs and permanent methods. So the study did, however, have a few limitations. The accuracy of documenting contraceptive initiation, continuation, and discontinuation. And they were also unable to determine the contraceptive initiation date. So by that, they could not ensure that the pregnancies occurred within the efficacy period of each contraceptive method. And they didn't know the pregnancy intention of the patients, but they safely assumed that for women on long-acting contraception, they intended to avoid pregnancy. So the Lancet published an article in October of last year where they state that subdermal implants remain a viable contraceptive option for HIV-positive women using efavirenz-based antiretroviral therapy. They do, however, advise that you should counsel the patients properly. Therefore, we have to question the circular released by our Department of Health in 2014, where they state that women who are HIV-positive and on efavirenz and already have the implant on inserted should be covered with another non-hormonal contraception, and they should be given the option to have the implant on removed. During March of 2014, the WHO convened a meeting of the Guideline Development Group for the purpose of reviewing and revising the medical eligibility criteria for contraceptive use. And the Guideline Developmental Group reviewed 4 systematic reviews of the available evidence conducted to address the following key questions. This is important, especially for the Part 2 candidates. The 4 questions that they asked were, does the use of a particular method directly increase the risk of HIV acquisition in women? Does the use of various hormonal contraceptive methods accelerate HIV disease? Does the use of various hormonal contraceptive methods increase the risk of female-to-male transmission? And are there any possible interactions between contraceptive methods and ARVs? So for the first question about HIV acquisition, they looked at 22 prospective observational studies, and they assessed the risk of acquiring HIV among women using a method of hormonal contraception versus non-hormonal contraception or no contraception at all. So for the combined oral contraceptives, they looked at 8 studies, and they were found to be informative but with important limitations and no significant correlation. For progestogen-only contraceptives, 5 studies were assessed on the use of Depo-Provera, and they were also considered to be informative but with important limitations. And 4 of them reported no statistically significant association with HIV acquisition, while 1 did. 9 studies assessed neuresterate and were also considered to be informative but with important limitations, and that showed mixed results. And 2 studies looked at implants, and neither reported a statistically increased risk of HIV acquisition. So for disease progression and the risk of transmission from female to male, no evidence was found with regards to that. The interaction between hormonal contraceptives and ARVs. For your nucleoside reverse transcriptase inhibitors, your protease inhibitors, and your integrase inhibitors, they do not appear to interact with combined oral contraceptives. One large study found that ARVs containing nevirapine did not increase ovulation or pregnancy rates in women taking oral contraceptives. But studies have shown that ARVs containing efavirenz decreases your contraceptive hormonal level and increases your ovulation rates. So before we look at the WHO recommendations, I always thought that Dr. Heinz van der Merwe is quite a profound supporter of Springbok rugby. But I found out that he's also supporting the Scottish football team. And I found this clip on YouTube showing him on Murrayfield in Edinburgh singing the national anthem. I just want to show you this. You look for him, he's in the yellow. That's him. So I was quite surprised to find that out, but we all can do what we like. Okay. So with regards to the WHO recommendations, they say for women at risk of HIV or women living with HIV, they recommend no restrictions on the use of combined hormonal contraceptives. Also, no restrictions on progestogen-only pills or progestogen-only injectables, as well as your implants. There are still unresolved questions currently surrounding the interaction between progestogen-only injectables and the risk of HIV acquisition. But the available studies have important methodological limitations hindering their interpretation. Some studies suggest that women using progestogen-only injectable contraception may be at increased risk of HIV acquisition, but other studies have not found this association. In 2014, the Cochrane database concluded that there is no high-quality evidence available as to whether or not hormonal contraception is associated with HIV acquisition. So in general, women taking ARVs are eligible for all hormonal contraceptive methods, but special consideration may be necessary for women using some hormonal contraception, some hormonal methods. So in conclusion, the WHO's commitment is to continually review the MEC recommendations, and it strongly supports the need for further research in obtaining answers with regards to HIV and possible drug interactions. And I hope you all have a good weekend.
So the bottom line with, hopefully you got from that, the talk, is that if you're HIV positive, there's no limitations to what contraception that you can use. There's no evidence to show that your disease of progression worsens. There is some evidence. There was a study that said that you could have an increased risk of transmission if you're using the injectables, but the bottom line of the WHO is that you must still, it doesn't prevent you from using it, but you need to counsel women to use dual protection, which they should be doing anyway. And then with respect to ARVs and hormonal contraception, yes, it does, especially efavirenz based, it does decrease the hormonal effectiveness of all the hormonals except for the injection. And also the bottom line from the WHO is advise about the decreased effectiveness and advise dual protection. And also the Kenyan studies came out last year, which just gave us more information to say that you can still use it. The implant is still a viable option with efavirenz, but what is the safest is an IUD. So for me, the take-home method is, if you want to counsel women that the most effective contraceptive, if you're on ARVs with efavirenz, is an IUD. So maybe we should.
And the MEC for IUCD?
It's if you're clinically well, it's a 2. If you're not clinically well, so you won't put it in if they've got AIDS and not clinically well. So that would be the only proviso. But in this, that you won't put it in. But as soon as they're on ARVs and clinically well, you can insert it. Okay, and so I'd like to have any questions from the floor. Is it all clear?
There's just some good news, and that is that there's a new single drug combination tablet that presently are going to be put in on trial in a randomized control trial comparing to the present one we're using. We hope to start with a study next year, early next year. The new combination drug consists of a new later version of tenofovir that's less nephrotoxic and also has less effect on the bone metabolism. And then it contains emtricitabine, and then the third one it contains is retolgravir, which is an integrase inhibitor. And retolgravir hasn't got an effect on, as Niels has actually shown. And this can be put together in a single dose tablet, and it's apparently not going to be more expensive than the present fixed dose combination. So hopefully we will have less problems in future, because we do have problems with efavirenz in various ways. For instance, there is a study that shows women on efavirenz commit significantly more suicide than on other type of ARV. So there are problems with efavirenz, and hopefully with a newer drug we can actually solve those problems by not using it in future.
Trying to find out, since this new information's come out, shouldn't we reverse that Department of Health circular? And Margaret Moss has written to the Deputy Director General, Jürgen Play. The problem is that they removed it from the essential drug list, and now so they were very hurried to remove it, and now it's taking a whole long processes to get it back on. Using efavirenz in the implant. So that's why there's this delay in reversing that policy decision. Okay. Thank you very much.